All right. Thank you very much, Carol. Good morning or afternoon to everyone, depending on when and where you are listening. We are going to take a look today at the code set itself for ICD-10. Take a look at some of the ways that it's similar to and some of the ways that it's different from ICD-9. Hopefully, for some people, it will kind of offset a little bit of the anxiety with the code set and things like that. For people that are current coders in the industry, it really is, you know, the guidelines and things like that currently are pretty similar to ICD-9, just of course with many, many more codes and extremely more specific. And that's really from an educational standpoint when you're talking with staff and coders and physicians. You know, the documentation issues that we currently discuss with the providers of the services are only going to become more apparent as we move into ICD-10. So we're going to take a look at a little bit of that. So for those of you that educate or that are looking to work with the system, you'll have more of an idea of the specificity that we're going to be dealing with. So why we are where we are is the final rule that came out on ICD-10. It was published January 16th, 2009, to give you a little history here. Of course, our compliance date for implementation is October 1st of 2013. The government has repeatedly stated that there will be no delays in the system because when you actually look at it from a historical standpoint, we were supposed to convert to ICD-10 in the year 2000. But, of course, with Y2K and we were all going to be hoarding water and living in caves, you know, they kind of put off the conversion and said we need to wait and we don't know what's going to happen with all the computer systems, and so they actually put implementation off. And after that, we just kept putting it off and kept putting it off. You know, we are the only country, the only large country that does not use the ICD-10 system. And so it was just got to be where, you know, it was time, but nobody wanted to kind of take the step. And the American Hospital Association, you know, on the facility side for the current coding system, the ICD-9 Volume 3 system, they were just literally running out of codes. They were putting things from one organ system in another organ system because there were no more codes left, and you know, I mean, it just and they were having to really broad base the categories for coding, so it caused issues, and they really, really needed to move to ICD-10 PCS. The two systems that we are going to use, we have ICD-10 CM, which is the diagnosis coding system, and we in our country will use the clinically modified version. That's what we have the CM on the end. Just as in ICD-9 now, we use the clinically modified version. And the clinically modified version is just stating that we're going to use it for morbidity, mortality tracking, and disease management rates and things like that. In other countries, you will see a different ending on the end. For instance, in New Zealand, they use ICD-10-NC. Canada uses ICD-10-CA. So sometimes you will see little ending letters there that will be different from ours. And then ICD-10-PCS is the procedural coding system. That is what the inpatient facility coders will use for their procedures. They will no longer, there will be no Volume 3 of ICD-10 like there is in ICD-9. So, and that system, we're not going to take a look at that one today, but maybe as we get closer, that might be another thing to take a look at. That system is totally different than the way that the facility coders code today. They really are going to have a big difference in what they are doing. And then they have to also learn ICD-10 CM. So facility coders are going to have two new systems that they have to learn. Also in that rule, it said that there will be no impact to CPT as it is right now, that for our providers we will continue to use HCPCS, the Healthcare Common Procedural Coding System. So we will use Volume 1, which is Level 1, which is CPT, and Level 2, which is our J codes and, those kinds of things. And then at the end of the slide, I did put the link so that you can click on it if you would like to go read the entire final rule, just in case, you need a little light summer reading. So going to the next slide, some of the final rule issues. Again, we have a single implementation date for all users, how they are going to do those dates. If you are a provider of service, you will use your actual date of service. So if you have a patient that you put as an inpatient on September 29th and they leave the hospital on October 2nd of 2013, you will code under ICD-9 for September 29th and 30th, and then you will cut your claim, and then you will start a new claim and do it with ICD-10 for October 1st and 2nd. For inpatient facility billing, you will go by date of discharge. So that same patient for the facility, it will be all ICD-10 on the date they left. ICD-9 ICD-9 codes will not be accepted for services provided on or after October 1st of 2013. So again, it will be date of service driven. Claims for services prior to that, of course, will flow through the system. They have left it very vague and say for a period of time. And then our electronic data transaction set, our 4010 that we use currently, will be turned to 5010, and that implementation date is January 1st of 2012. The 5010 transaction set will allow us to be able to send ICD-10 codes, so it will expand the character lengths and things like that to accept the 7 digits. For PCS, there is no decimal point in the system, so it makes some changes. The biggest thing is for us to be able to send the ICD-10 codes. There's also going to be some other changes with it, too, with NPI and with patient-to-subscriber relationships and other things like that that will come along with updating to 5010, too. But the biggest thing we cared about was, that it will let us take the ICD-10 codes. It will allow us, as a little side here, too, for 12 ICD-10 codes, 12 diagnosis codes to be sent per line item. So it will expand that. Currently, with the new 4010 that we upgraded to recently, it expanded it out to 8. But then it will, with 5010, go to 12. So there's kind of like no excuse not to be able to tell your whole story with your diagnosis codes after we convert over to that. I think that's more than enough room. Although probably somebody will find where they're going to use them all, I bet. On the next slide, we're taking a look at a comparison from 9 to 10. Of course, ICD-9, we have out to 5 characters is the highest specificity that we can get. With ICD-10, we can go out to 7. As you can see with ICD-9, we are sitting at about 14,000 codes. With ICD-10 CM, there are currently 70,000 codes around. With ICD-10 PCS, the procedural coding system, there is an additional 78,000 codes for that. So when you add those two together, it's just an enormous number of codes that we're going to be moving to. So for you IT people, thinking of system-wise and power and memory and all that kind of stuff, that's kind of what we're looking at. With ICD-9, we do have some alphanumeric codes with our V codes and our E codes. ICD-10 are all alphanumeric, and they all drive with an alpha character. So they do not use the letter U in ICD-10 CM because they thought it might be confusing, but they do use I's and O's, even though some people may confuse that with 1s and 0s. They decided to go ahead and use it. And the capital I that they drive with in ICD-10 does kind of look like a number 1. It doesn't have the top hat and the shoes. It's just like the little stick figure. So you have to be careful when people are writing out things, too, that everybody is understanding how the system works so that they know, well, if it looks like a 1 at the front or an L, is it an L or is it an I? Is it, is it an O or is it a 0? So those are some of the things to kind of be working over in your brain a little bit too, about when you're, not so much when you're typing things in the computer, but more when people are writing things out to make sure everybody's understanding what's getting written, because the codes will be alphanumeric in ICD-10. They can be alphanumeric all the way through. So they can start with an alpha character, they can end with an alpha character, they can also have some alpha characters in the middle. So it could be, you know, alpha digit, digit, alpha, you know, so you just going to have to you know, watch the code specifically. And then, of course, with ICD-9, one of the big problems was there was not a lot of space, especially in Volume 3, for new codes. They were just running out of room. And the way the PCS system is set up, and ICD-10 CM, just because of the sheer number of codes, and going out to 7 digits, we have much more space and room than we could ever get with ICD-9. One of the other things, though, is they are very specific codes, which means that when you are looking at documentation or looking at sizes for inputting information to be able to hold all of this stuff, the codes are much more specific than what we have in ICD-9. And sometimes that means you will use less codes because the code is, they have a lot more combination codes in ICD-10. But sometimes you end up using more codes because the codes are so specific, you need to use a couple to say the same thing that you used to say in ICD-9. So it kind of is a half and half. You know, you'll notice with some things you're coding less and some things you're coding more. In ICD-9, with the diagnosis coding system, there was not laterality in the codes. With ICD-10, that's a big change. For the diagnosis coding system, we do have laterality. So we have rights and lefts and bilaterals in the actual diagnosis code. So that's a little bit different too. And once again, from a documentation standpoint, that's something else to be working with your providers on to make sure. And some of the examples that I have in the slides at the end will show where, you know, you look at the note and it's never mentioned in there what the laterality is. And so for the new system, those things will have to be sent back to the provider for them to, you know, make an addendum in the note to specify the laterality, the right, the left, the bilateral, so that, you know, we can make sure that we can code it and get it out the door to get the claims paid. With ICD-9 to 10 too, you know, with the specificity, we'll have much more accuracy for data analysis for grants and funding and things like that. So this just kind of gives you an idea of what we're looking at moving into our new system. So this next slide just kind of shows a little circle of life, if you will, for ICD-10 and just all of the different places it's going to impact. It's just about anything in an office. If it has to do with patient care, is going to be impacted by ICD-10. And the biggest thing I always put in front of people when I talk about ICD-10 is always be thinking about the productivity. You're going to have a loss of productivity when you switch over to ICD-10. As soon as you start planning for it, you are going to notice a loss of productivity a little bit. But the longer you wait, the bigger the drops you're going to have. You know, the more preparation you do, you know, the less you're going to notice it. So it's something, you know, with the super bills, you know, can you even use a super bill? In my opinion, for ICD-9 coding, for diagnosis coding, it's going to be pretty hard. We took a super bill and just looked at the ICD-9 codes on the back, and the backer went from 1 page to 8 or 9 pages long, converting just those codes over into ICD-10 CM codes. So, you know, I don't even know if super bills are going to be possible for diagnosis coding under the ICD-10 system. It'll be like having an accordion file attached to the back of every patient chart, you know. Cash flow disruption. You know, if claims and if the claims are being held because we need more specific information to be able to send out a diagnosis code to get it on a claim, you know, that's going to disrupt the cash flow in the office. If there are being more denials coming from the payor because they are not having the ICD-10 specificity in the code that they're looking for, and you have to resubmit. That's going to cause a cash flow disruption, which of course is going to be in productivity too. People working those, more denials being worked, more appeals, more of going back to the providers and asking them for more specific documents. The more hands that touch that claim, the more times that touch that chart, the longer it's going to take, less, productivity, and, hitting the cash flow. The IT systems, impact on our documentation that we're looking at by the providers, changes in business processes, all of those things, everything is going to be impacted by ICD-10. So provider impact I talked about a little bit already. We're looking at diagnosis, procedures, looking at supporting their medical necessities, so just being much more specific in their documentation because of how specific those code sets are. And we talked about the denials and the additional documentation that may be necessary that they need to look at. For also coverage and payment, the new coding system will mean that we have new coverage policies, new medical review edits, reimbursement schedules, all those kinds of things, and your patients. Don't forget about the patients too, having to discuss ICD-10 with patients so that they understand, how come this always got paid and then all of a sudden now it's getting denied, because of the system change. Contracts with the plan, there will be more. The coding will need to be more specific. Look at the LCDs, those local coverage determinations, and NCDs that Medicare sends out. Imagine what those are going to be looking like once they convert those over and put out, instead of ICD-9 codes that meet medical necessities, the ICD-10 code list that will meet medical necessities. It's going to be huge. Billing and eligibility transactions, looking at those things. The lab orders, that's an issue these days with a lot of offices, is the lab and how they can receive information. It's going to be more imperative under ICD-10 that the offices are more specific when they're ordering things with diagnosis. Coding and documentation, I've already kind of touched on, inconsistent, missing, conflicting, unclear documentation, these kinds of things. If it's not worked on now, when ICD-10 hits, there are going to be a lot of denials coming and things like that. So we want to make sure that we have our providers where they need to be so we don't get hit with that as much. Health plan impacts, they will have to redo all their contracts. They'll have to redo their coverage determinations, their payment determinations, their medical review policies, all of these things I have listed on this slide. So they are kind of neck deep, if you will, in ICD-10 preparation right now. They're working on all of these things. They're having to map over all of their policies from ICD-9 to ICD-10. So they are heavily working in this system already. And because of that, they're also getting lead time at looking at it and seeing what they will and will not accept as far as diagnosis codes go when October comes around in 2013. The billing and collections, looking at the patient-provider plan confusion, increase in denials. My opinion is there probably will be increase in denials. Nobody's systems, how that goes. Our systems probably are not going to be working perfectly 100% of the time everywhere. And just because the coding system is so much more specific, there will be more things that the provider or that the payor may be denying out due to medical necessity. So medical necessity denials may even be increasing more than they already are today. And again, patient misunderstanding of what their coverage will be now because of the specificity of the coding system, that maybe something that used to get paid the way that the code split out under ICD-10, maybe it won't pay it anymore. So, and most patients or some patients that, unless they've been specifically trained in how to read those and look at those and understand the system, may not know that they don't have coverage for something anymore. That older debt versus newer services, from a collection standpoint, I would say to have people working ICD-9 appeals and people working ICD-10 appeals. you know, so that you have that split off in the office and people can concentrate to try to get those older services cleaned up so that everybody can be moving on with the new stuff. Privacy concerns, of course, because of the significant amount of detail, just being more careful with privacy and, you know, maybe watching for HIPAA to see if they make any kind of adjustment for ICD-10 as we get closer to using that system. Now, changes, what we're looking at as far as changes with ICD-10, many more injury codes in ICD-10 than in ICD-9. In ICD-9, we have E-codes, what we call E-codes, that we have in the manual that go through, like you were in a car accident or you fell down the stairs, those kind of things, external causes of injury. In ICD-10, they go from V through Y, so they have greatly expanded those codes. And it's kind of interesting. That's kind of the fun part of the book. So if you want to sit and go, wow, I can't believe that they're getting that specific. I mean, they have codes for in the kitchen of a single dwelling residence was a place of injury while the patient was baking cookies in the oven. You know, that, you know, we have codes that will show that that's what was going on when you got the burn. So they are, and if we're getting paid to do that, there's another code that will show you were getting paid for it at the time. So they're looking also at subrogation issues for liability, responsibility of the bill. We have many more combination codes in ICD-10 than we get in ICD-9. So as I had said before, sometimes that's a dual sword. It may mean that there are more codes. It may mean that there are less codes. It just depends on what specific case you're looking at. The V&E codes that we use today are incorporated into ICD-10, but instead of being supplemental, they're actually chapters of the manual, so they have them as main parts. And then, of course, the length going to the 7 digits. There are 7 characters. With it, looking at the number, ICD-9, we have 14,000, a little over codes today. In ICD-10, currently today, there are about 70,000 codes. So just a big, looking at the numbers flat out is just kind of a, you know, a big jump for us. Now, they are set up, as you see here on slide 14, the first 3 characters, just like we have today, they still, we'll call it your rubric of where your codes start. And then you have subcategories, the 4th and 5th characters, which just get more specific to site and etiology and manifestation. And then it goes up to 7 characters. Not all codes are 7 characters long, but we have 7 character extenders. Just like in ICD-9, we're used to seeing the 4th and 5th digit boxes. You will see 7th character extender boxes in ICD-10. So when they do use them, they try to group them together in a little, you know, box for you. The main ones are the letters A, D, and S. But in the musculoskeletal system with fractures, there are many more of them that you may use. And they get varying different pieces of information. We'll look at those in another second here. But just again to kind of show you in a little box format there on slide 15 with the category, the etiology, site, severity for the 4th, 5th, and 6th digit, and then the extender as the 7th character. So here are some character categories or rubrics. At the beginning of every chapter, it will tell you what chapter you're in. Like chapter 1 is certain infectious and parasitic diseases in ICD-10, and then they will have, after that, it will have some includes and excludes notes, and then it will show you the blocks. And here's an example here, or the rubrics and sets of where they are. So A00 through A09 is where the intestinal infectious diseases are. A15 through A19 is where we will find TB or tuberculosis. A20 to A28 is where they will have the zoonotic bacterial diseases and so on. So at the beginning of every chapter, you'll see this. Chapter 2 is neoplasms. You know, so it matches up for the most part with ICD-9 until you get to like the nervous system. In ICD-10, they have separated out the nervous system, the eye, and the ear into 3 different chapters. In ICD-9, it's 1 chapter. Now, when we go to the 4th characters here, then you can see how it gets further defined. It gets more specific. So C15 would be the rubric, malignant neoplasm of the esophagus. And then we have C15.3 if it's of the upper third of the esophagus, C15.4 if it's the middle third, C15.5 if it's the lower third, and then C15.8 if it's overlapping portions or thirds of the esophagus. So it's in the upper and the middle. And then C15.9 would be if it just says CA esophagus, and we don't know. Or maybe the provider doesn't know yet. They know the patient has cancer in the esophagus, but they haven't done a scope yet, so they're not sure where exactly or which third or how many thirds it is in the esophagus. But as you can see just from this example, and that's just out to the 4th digit, the 4th character of how specific the code set will get. And then the 5th and 6th, as you can see in this example, is even more specific. We have S55.011 for a laceration of the ulnar artery at the forearm level of the right arm. Now, in this code, we would need a 7th character extender also to say where the episode of care was, where they were in treatment. But just to give you an example of how specific, again, going out to the 6th character that the codes can become. Now, the 7th character extender, as I talked about before, they'll have a little box, and you have to have a 7th character for all the codes that apply in that category that are shown in that box. And the 7th character always has to be the 7th character. What that means is we will use dummy placeholders in ICD-10 when we do not have information in maybe the 5th and the 6th character. There's no coding information there. You can't move the 7th character extender up and truncate a code. You have to stay at the 7th character. So we will use X's in ICD-10 as dummy placeholders. So that's different than how we do it in ICD-9. We don't have such a thing in ICD-9 right now. You just code as far as it goes, and that's it. So in this case, in ICD-10, we are going to be using X's. Here's a couple that show the 7th character with some meanings of them. Going back to that example I used before, S55.011, our 3 7-character extender choices would be A for initial encounter, D for subsequent encounter, or S for a sequela or a late effect. So a final code, as you see there, with all 7 characters used, could be S55.011A for a laceration of the ulnar artery at the forearm level of the right arm, initial encounter. Now, they use that term a little differently than what we are used to also in, today, in that when we think of subsequent, we think of like initial and subsequent. Initial is the first, it's over and done with. Now you're having subsequent visits or subsequent encounters, so that you will have one initial and everything else is subsequent. But under ICD-10, how they look at it is more like initial treatment. So if you have a patient, let's say that fractures their arm and shows up at the emergency department on Friday at 2 in the morning, they would use a 7th character extender of A for initial encounter. And then when they went to the orthopod on Monday to get it, fully treated, then that orthopod may also use A for initial encounter. So in ICD-10, initial encounter really means initial active treatment. So if you think of it more that way, A, active treatment, it might help a little bit with the 7th character extenders. So here are some more examples of using the different endings. T50.B96A would be an underdosing of a viral vaccine, the initial encounter. T50.B96D would be a subsequent encounter, and T50.B96F would be a sequela. And as you can see, these also show an example of how we may see the alpha and the numerical characters you know, going back and forth throughout the code sets too. And here's an example to show you those dummy placeholders, those X's that we will use to go ahead and fill out the code so that we can have a 7th character staying the 7th character. In this case, we have O33.5XX0. So now in the OB categories, the 7th character extenders are mostly going to be numbers for the number of fetuses, which fetus is being looked at. So in this case, if it doesn't matter for the code, it's not applicable to the code, or we don't know, it's a 0. A 1 is fetus 1, a 2 is fetus 2, etc. In ICD-10. So it starts with an O, O for OB, that's where we're going to find our OB stuff, and then it ends with a 0. But you have the dummy X's there in their place to hold it so that the 0 can remain the 7th character. So here's another example, patient not wearing a seatbelt involved in an auto accident. They hit the windshield, they go to the ED, and they have a laceration to their scalp. So we have S01.01XA for a laceration without foreign body of the scalp, initial encounter. So also in ICD-10, we have excludes and includes notes, just like we have in ICD-9. But in ICD-10, we have a couple different kinds of excludes. We have excludes 1 and excludes 2. Excludes 1 means we should never use these codes together. They don't belong together. Either the documentation's wrong or we're understanding something wrong. An example here would be type 2 diabetes and type 1 diabetes or gestational diabetes. You can't be both. You can't be 2 of those. You can't be all 3 of them. You have to be one or the other. You know, so these never go together. And excludes, one example here would be, so that's excludes 1. And excludes 2 would be when you may be coding these things together. An example would be if a patient has acute on chronic tonsillitis. They don't have an ICD-10, a combination code for that. So when you see them in ICD-10, you'll see J03 as an example for acute tonsillitis, and then it will say it excludes 2 chronic tonsillitis, meaning that if the physician documents acute on chronic, then you would code the J03, and then you would also continue and go and code the chronic tonsillitis. So you would need 2 codes to show the complete condition. So that will be your excludes. And then our includes are the same as our includes now in ICD-9. We also have laterality. We talked about that in ICD-10. In the guidelines it says the right side is always a 1, the left is always a 2, and bilateral is always a 3. And so I printed on the PowerPoint slide exactly as the guidelines say, but that's not always true. Now, you won't see where a 2 means a right. They don't do that, but sometimes they will use like a 7 and it'll be a left. So they don't always hold to this, but the guideline does say always. But just understand that, you know, it really isn't always. And then we will have 0 or 9s for our unspecified, depending on which character, you know, it falls into the code. So it's kind of like we have an ICD-9 now, like with asthma and things like that, where we have the unspecified, we'll see 9s being used. That's going to hold true for ICD-10 also. So here's some examples of the laterality. So we have C50.212 for the left female breast, so the 2 for the left. And then see, here's an example, H02.835, which is of the left lower eyelid, dermatochalasis, but it doesn't have the 2 for left there. And then I80.01, which would be phlebitis and thrombophlebitis of the superficial vessels of the right lower extremity, because it has the 1 there in the 5th character. And then L89.213 for a pressure ulcer of the right hip of stage 3, because again, it has that 1 in the 5th character. So most of the time, those numbers are correct. Sometimes they are not, though. And also notice with that phlebitis and thrombophlebitis, the I-80.01, that first character is an I. And some people are having a little trouble with that as, is that an L, is that a 1? So you have to be very careful with the alphanumeric characters in ICD-10 from a visual standpoint. The biggest change in ICD-10 from a coding standpoint is probably going to be diabetes here. With diabetes, we are going from the 250 rubric that we have in ICD-9, 250.00, 250.10, 250.2, those, to over 150 codes for diabetes in ICD-10, and that's currently today. So we have 5 different categories for ICD-10 for diabetes. We have E08 through E13. They actually had an E14 for unspecified diabetes, but they deleted it, so we don't even have that now. There were 6. So now we have these 5. E08 is diabetes due to an underlying condition. E09 is drug or chemically induced diabetes. E10 is type 1. E11 is type 2. And E13 is other specified. So here, looking at the next slide, the codes are expanded for classification and manifestation, so they made them into a bunch of combination codes is what they did. So no longer are we going to have to look at the controlled or uncontrolled issue from an ICD-10 standpoint or from a world view. They are looking at it from the clinical classification of diabetes. So the controlled or uncontrolled is no longer a coding issue under ICD-10. So you see some examples here, E08.22, diabetes due to an underlying condition with diabetic chronic kidney disease, E10.11, type 1 with ketoacidosis with coma. So as you can see, much more specific with the things that we now use, multiple codes to try to say in ICD-10, they've bundled them together. Here's an example, 45-year-old who goes to the office for a 3-month follow-up. They're a type 2 diabetic. They've been on insulin, though, even though they're a type 2, because they haven't had good control with their diabetes. So in this case, we would have E11.9, type 2 diabetes without complication, because remember, we don't have controlled and uncontrolled in ICD-10, and they don't mention a complication necessarily, just that it's not in good control. And so they're going to keep them on insulin. And we do have in ICD-10 a Z79.4, like we have our V code today in ICD-9 for long-term current use of insulin. So you would use those 2 codes together to diagnose that visit there for the patient. Then we, of course, are looking, as I had said before, because of the combination codes, you can see here examples of a couple of them that will give us that greater specificity in the system. So I25.110 is arterial sclerotic heart disease of the native coronary artery with unstable angina pectoris. K50.013, Crohn's disease of the small intestine with fistula. So they combine these together, so we will use less codes for them. And K71.51 for toxic liver disease with chronic active hepatitis with ascites. So just as we're looking at things, it will take us as coders, the people that code, probably a little bit longer because they're all combined to, come to the right one when they get to so many combinations that they have to go through to pick out which one is the correct one that they need, even though they may end up using less codes for the case. And then here's with complications as an example too. With ICD-10, we have 50 different codes for complications of foreign bodies accidentally left in the body following a procedure, and we only have 1 in ICD-9. So just an example both of, just the sheer number of codes and the specificity of what we're looking at from 9 to 10. Here are some examples for complications. T81.535, perforations due to foreign body accidentally left in the body following a heart cath. Obstructions, adhesions, different things like that. So as you can see, they're very specific to sometimes the procedure actually being performed, sometimes to what the complication is specifically. So just a lot more information that we're going to be able to track under the new system. Another one is a laceration S31.623A for laceration with a foreign body of the abdominal wall of the right lower quadrant with penetration into the peritoneal cavity. Initial encounter. You know, I mean, these are like a mouthful just to try to get through a code, with, of course, notating that the 7-character extender are there. So that is a full, all the way out 7-character code. Fractures. With fractures, here are some of the extenders that we may see with fractures. They are looking for much more specific information. So we can have A still for initial encounter, but we'll have A if it's a closed fracture, a B if it's an open fracture, and then we even have to look for if it's subsequent, where are they in healing? Do they have routine healing? That would be a D. If it's delayed healing, it would be a G. They have malunions, non-unions, all those kinds of things. So with fracture coding for the orthopods, they need to be much more specific in their documentation for ensuring that we can get a claim out, because you have to have the 7-character extender for those. So without this information, the claim is just going to sit because we can't complete it to get it submitted to get paid. So those are the kind of things that we're looking at to ensure that we get the information ready so that we can get it out. Here's a little example. Patient undergoes surgery for an open burst fracture of the lumbar vertebra, which became unstable. So we would have S32.012B. The B would identify that it's an initial encounter for an open fracture. Now, looking at a few case examples before I open the questions. It's just a couple quick ones to go through to look at here. Here we have cellulitis and superficial abscess of the index finger. So that looks like a pretty specific code or diagnosis, and under ICD-9 standards it would be fine, but under ICD-10 standards, notice that it doesn't give laterality. It doesn't tell us whether it's right or left. You know, they're recommending debridement, they're giving them clindamycin, and they're going to check her back in 3 days. So when we look at the next slide, what we did was we entered the code into the GEMS map, into the lookup tool that is on the AAPC website, and 681.00 is cellulitis and abscess of the finger under I-9, and you can see all the different choices that we would have under ICD-10 to try to look at it. Notice that they have abscess as one code, cellulitis as separate codes. So in the case for what we were looking at, we would need multiple codes to describe that in ICD-10. Plus, if you look at L03.011, it's the right finger, L03.012, the left finger. So we also do need to know, looking at those codes, which finger it is so that we can code it out properly. Another one here, we have a foreign body in the nose. Patient 3 to 4 months old, they came in today because they stuck the raisin up their nostril and the grandma couldn't get it out. So the raisin was grasped with bayonet forceps, removed atraumatically. Exam of the nostril fails to reveal any further foreign body or problems. Diagnosis, foreign body removal of the nostril. Once again, looking at that, we don't know, is it the right or the left? Did they stick raisins up both? You know, so is it bilateral? We're not able to code it without that information. Also, we're assuming it's the initial encounter that they're coming in for this raising up the nose thing. So the 7th character extender would be an A in that case. But, you know, we would have to also verify that. So you can see also in the GEMS map here from 932 in ICD-9 to the T17s in ICD-10, and you can also see those dummy X's, those placeholder X's being used there too, because the A would have to be the 7th character. Another case example here, placenta and AF. Placenta is posterior, anterior, grade 0, amniotic fluid is within normal limits, no abnormality seen. The impression is 24.6 weeks by measurement. Fetus is 701 grams. But it is not listed as to, looking at the code set, we need to know the trimester they're being seen in. The Z34.00, we have those supervision codes in ICD-10, like we have the V22 code in ICD-9. Now, one little difference as an aside there between 9 and 10 is in ICD-9, we have V codes for supervision of normal pregnancies, and we also have V codes of supervision of high-risk pregnancies, whereas in ICD-10, if it's a normal, quote-unquote, pregnancy, they have it in the V code like you see here, which is ICD-10's, V code. That's the kind of mapping, whereas on to the supervision for high risk, those are actually part of the part of the code set itself. They don't consider those as kind of external supplemental codes. They consider those as an issue, and if it's an issue, it belongs as part of the code set. And then the last case example, we have a stable knee under exam, under anesthesia. They did an arthroscopy looking at smooth articular surfaces throughout the entire knee. He's got a lateral meniscus that's normal. He has a locked bucket handle meniscal tear, and they excised it. They did excision of the tear. Cruciate ligament is intact. Once again, looking at that case study, you see absolutely nothing that tells us which knee is being worked on. So I think, and those example after examples I've been showing, these are actual cases that we have told. And I think for, especially for orthopedics, that's really going to be a problem in their specialty is to really hit home with them that they have to take a look at that issue of the laterality to make sure and ensure that they are putting that information out there so that it can be properly coded and it doesn't get held up. As you can see here, just looking at the map, the 836.0, and then going in to the possible codes that it could be in ICD-10, this would be considered a one-to-many map, which means that you have one ICD-9 code but many ICD-10 codes that it may map to. And as you look, you have the bucket handle, a peripheral tear, a complex tear, other type of tear, and it goes left to right. And then which encounter is it? So, if you also add the other kinds of encounters you could have for 7 characters, you could triple the codes that this could be. So, just the sheer number of choices that we're going to have are much more in ICD-10. So we have to get more specific in looking at the information that we're giving. And the last couple slides are just to show you some of the resources on the AAPC website for ICD-10 and some of the things that you can go in and look at, and they're free of charge. So if you go to aapc.com and kind of look at these things, you can pull up that little GEMS map thing that I was using a minute ago in some of the examples. You could go to the code translator and convert the 9 to the 10 to kind of see the possible number of codes you might have, and links to studies and reports, the RAND study, the Nolan study. Those things are out there on the site. And, of course, they have like a little group discussion thing where you can get in one of those little discussion group kind of things. News and articles, all those different kind of things on there. So it's a really good tool. They also have a benchmark tracker, and we'll take a look at that tomorrow when I talk about the implementation. It's like a free benchmark tracker, so you can track your progress by the size of your practice to where you are today, to where you need to be to get to ICD-10 implementation. So it's kind of neat. There's the translator again that I was using before, so it just shows you another shot of it there. And you can go from 9 to 10 or 10 to 9 if you want to kind of see what possibilities you're looking at. They also have this little tool here that shows you this little office picture, and if you click on anywhere in the office, it will show you how ICD-10 affects that part of the office. So once again, for other people, just to give them an idea of how far-reaching ICD-10 is and what all it will touch. You might not have thought of something, and you go out there and go, oh, wow, I didn't even think of that. So just kind of a neat little thing out there. And then just some different tabs on looking at providers versus health plans. There's also free streaming on there for some audios that were made a couple years ago where you can download the PowerPoint, and Deb Greider, who was speaking on ICD-10 for health plans and for providers. So that's something else that's available out there too at no charge. Then the last slide just gives you some resources, to go to the cms.hhs.gov for the ICD-10 list of code sets and the official rules and the guidelines and things like that. And then the AAPC and the Physician Services websites, if you want to go look there for more information on assistance with getting into ICD-10. And now, Carol, I will be ready to open it up for questions. I also put my email address out there for people if they want to, get a hold of me by email also.
Great, great. That was a ton of information. Again, just to remind everybody that this two-part series concludes tomorrow. We're going to look at implementation. Betty's going to look at implementation and talk about the 3 T's: timelines, teams, and training, right? and whatnot. So again, many of the questions that I've got really relate to this recording and your slide presentation, both of which will be made available within 24 hours to take a look at. We did have a couple questions really related to CMS. A couple people asked if they're going to make a hard copy available. Will there be a new CMS 1500 hard copy?
I am not sure. I know currently, we have the 1500, but using it on paper, of course, costs us delay time in getting our claim, paid. I have not heard that they're going to take away, the paper claim. I know that they are just going to start, knocking us more and more and more, I think, from not sending stuff electronically. But I don't know that they've, said anything about, that's one of the things with the 5010. I'm sure they'll probably have a new, if you notice with the CMS, the 1500, the hard copy, when they did the 4010, the last conversion they made, the 1500 changed a little bit. And some of the finer ones was if you looked at the ICD-9, the diagnosis coding thing, those boxes got a little longer. and that was to kind of prepare for ICD-10. So, they kind of have made little, plays with it already. So we probably, I think, we'll probably get a new hard copy 1500, yes. As far as when, they probably, the 5010 conversion for electronic data set has to be done by January 12th of 2012. So I would imagine for the hard copy form, for ICD-10 purposes, we'll probably see that sometime after that and before, October 1st of 2013. And that's just my opinion because, I haven't officially seen anything, but that's what I would think.
Another member asked, can you speak a little bit to the impact to long-term care facilities? For example, what about aftercare of a fracture of a hip, as an example?
Yeah, from just from an ICD-10 standpoint, the staff that does the coding of the cases, they're going to, from a productivity standpoint, looking through, it's just going to take them a little longer coding out the cases and getting and making sure that enough information is in the medical record to ensure that they can code them out properly. I think that for everybody, not just LTCs, but for all anybody that's touching chart documentation, in looking at that more specific information to make sure we have complete information for those episodes of care and things like that. Once the patient has reached a long-term care facility, are they still in active care treatment? Is that initial treatment at that point, or are now they going into subsequent care because they've had their surgeries and something didn't go right? Are they late effects? Are they having sequelae from it that's driven them into the long-term care facility because of comorbid conditions? There probably is going to have to be a little more digging done on the medical records department, or a little more push put on to the providers about what you need for, you know, documenting in those records to make them complete.
Sure. And another question, do you know what impact this change will have on behavioral and or psych facilities?
Oh, no, I am not, I don't have a, you know, I know from a coding standpoint, from the procedural coding system, from the inpatient standpoint on PCS, they have a separate section in PCS on it. The codes are pretty unspecific, to be honest, you know, because, I mean, in PCS and the procedural side, all the codes have to go to 7 characters. There's no, like, 3 or 4. They all go to 7. And so they more look at the type of facility it is and the type of treatment being given. And so there's a lot of, in PCS, the dummy character or the fill-in instead of an X is a Z. So in those kind of coding on the procedural side, it's full of a lot of Zs. You know, out of the 7 characters, I believe 4 of them are like Zs for them because there's not much tracking or there's not much specificity that they're looking for in that system yet.
Right.
I think from the CM, from the diagnosis coding standpoint, just more specific, you probably will be using more codes for, you know, like bipolar with manic depression, with this, with that. You know, they're probably going to be all specifically coded out in ICD10. I'd have to do a little research on that, though, to say 100% that was a fact. I know from a guideline standpoint, there aren't any specific guidelines to that section of the code set yet.
Okay, great. All right. Betty, thank you so much for your time today. We're right at the top of the hour, perfect timing. And again, reminder to everybody to register for tomorrow's conclusion where we talk about implementation, or Betty does anyway. And we'll see you tomorrow at the same time. And thank you, everyone.
Thank you.